Good afternoon and welcome everyone. Thanks for joining us today. I'm Lee Yates, co-facilitator of the TBC at UBC Network and clinical associate professor in UBC's midwifery program in the Department of Family Practice within the Faculty of Medicine. Today, I'm joined by Christy Newton, my TBC at UBC Network co-facilitator and associate professor and associate head, education and engagement, also in the Department of Family Practice within the UBC Faculty of Medicine. Thank you for joining the network event today. Before we start, I'd like to acknowledge that the UBC Vancouver Point Grey campus is located on the traditional, ancestral, and unceded territory of the Musqueam people, and the UBC Okanagan campus is located on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. I would also like to recognize that UBC's activities take place on Indigenous lands throughout British Columbia and beyond, and that you are joining us today from many places. And I acknowledge the caretakers and the owners of those lands. Myself, I'm attending from the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And please feel free to share the lands from which you are joining in the chat if you wish. I will now hand over to Christy to share more about the TBC at UBC Network and today's event.
Thanks, Lee. So I'd like to start by acknowledging that I'm grateful to be attending from my home office in Port Moody, which lies on the shared unceded territories of the Coast Salish people. For new participants, and perhaps a refresher for those returning participants, I'm going to start with a bit about the TBC at UBC Network. So the TBC at UBC Network is supported by UBC Health, which works under the Office of the Vice President Health, with a mandate to help address complex challenges affecting the health and well-being of individuals, communities, and society. UBC Health facilitates collaboration across disciplines, faculties, external partners, and communities to improve the ways we train people, develop knowledge, and shape policy to ultimately address inequities and improve the systems that foster and support health. The TBC at UBC Network serves to bring together health professionals and leaders, community members, academics, and policymakers to bring forward questions and ideas important for team-based care in British Columbia. The network supports and complements province-wide efforts to enhance team-based care in BC. And it focuses specifically on education, research, evaluation, and knowledge translation. We apply, so the network enables participants to connect, to share, to learn, and we focus specifically on different lenses. So we look through the themes of research, pedagogy, and innovation. Today's session, we're welcoming the leaders of Change BC, which is a team-based approach of integrating nutrition and exercise into effective personalized lifestyle interventions for patients. This collaborative program was developed by dietitians, kinesiologists, family doctors, and patients to improve the health of all Canadians. Speakers representing this unique partnership will ask us as participants to raise and consider ideas, issues, and questions about developing team-based care with novel disciplines and roles, and giving, again, special consideration to research, health professional education, and innovation. So we'll begin the presentation with a presentation from Change BC. And after, there will be an opportunity to engage further with our speakers in small group discussions. And then the last 30 minutes of the session from 1 to 1:30 is a space for informal discussion and networking with our speakers and fellow TBC at UBC Network members. And we hope that you can stay for this time. So now I'm going to hand it off to our panel, our Change BC team, starting with Lori, Colleen, and Stacy.
Good afternoon. I'm Lori Flood, Chair of Metabolic Syndrome Canada, which we affectionately call METSI. This is a very personal story about two very special people, my parents, Ken and Rachel Flood. My mom had a surgery that didn't go as planned and led to 30 more surgeries over about 40 years. We spent a lot of time as a family in hospitals. My dad is a successful entrepreneur, and he spent a lot of time talking with doctors. And he would ask them, if there was one thing you could change in healthcare, what would it be? And the answer that he heard most often was, I wish that my parents would exercise more and eat healthier. One of the doctors who cared for my mom was Dr. Chris Boy. He's an internationally recognized doctor for research in the fields of gastroenterology, nutrition, and disease. Dr. Gigi Boy and my dad came up with the idea of creating a practical clinical application of the best research. They built a volunteer team of experts across the country, ultimately founding METSI, a charitable organization that created the Change program. Next slide. Chronic disease is a crisis in our country. 1 in 5 adult Canadians has metabolic syndrome, and they don't even know it. Diabetes and cardiovascular diseases account for 43% of all deaths in Canada. We have a huge opportunity to shift billions of dollars in healthcare costs from acute care to prevention. Next slide. We created the Change program in 2013. We spent $2 million developing and then following a rigorous process of studying 309 individuals across 3 provinces in Canada, and we got impressive results. There were no fads, no gimmicks, and no profits. The complexity of taking care of your health is overwhelming, and it isn't working. People need a team to simplify and personalize their healthcare with a trusted scientific approach. The Change BC team is leading the country. You know, I work with teams in provinces across the country, and their focus on cultural safety, operational efficiencies is second to none. I'm so honored to be working with them. Colleen, do you want to tell more about that?
So why is this Change BC work so important? So over 1.5 million people in BC have diabetes or metabolic syndrome. The Public Health Agency of Canada predicts 2.16 million new cases of diabetes this year, corresponding to about 15.36 billion in healthcare related costs for diabetes. And patients' out-of-pocket expenses really range from about 800 to 4,700 annually. Through the Change BC team-based care model, back in 2018 and 19, during a pilot, about 32.4% of patients who completed the initial program were able to reverse metabolic syndrome and type 2 diabetes. These results are excellent and some of the very best in Canada. Many patients became so much healthier through Change BC, individualized nutrition and exercise supports together with their family physician, that they were actually able to stop medications. Physicians leading this work estimate that without Change BC supports, only 1% of their patients are able to reverse metabolic syndrome and diabetes, type 2 diabetes on their own. You might be aware that the family physicians leading this Change BC initiative have been recognized by the BC College of Family Physicians, the Rural Coordination Committee of BC, the Pacific Northwest Division of Family Practice, and also the Canadian College of Family Physicians. The innovation underway here is making a measurable difference to the lives of patients. In terms of striving for health system excellence, for those of you that follow the world-class work of Dr. Dawn Berwick and associates at the Institute for Healthcare Improvement, you'll recognize the triple aim, also known as access improvement measures, which has evolved to the quintuple aim. This internationally recognized approach of aim excellence and health system transformation is exactly what we see with Change BC, improving population health, enhancing the care experience of each patient, reducing the per capita cost of healthcare, attaining joy and meaning in family practice, which is very important, and critically, health equity for patients, together with cultural safety for all patients. I'd like to now turn the presentation over to Stacey Tyers, our Regional Doctors of BC Transformation Partner, for her wise words.
Thank you, Colleen, and good afternoon, everyone. I'm the primary care transformation partner with Doctors of BC, supporting the General Practices Services Committee mandate. What makes me incredibly excited about being able to support the Change BC program is I support all of the North in healthcare transformation, primarily through partnerships and team-based care. And the Change BC program absolutely represents exactly what the General Practices Services Committee has been hoping to be able to support throughout the province. Through partnerships and through innovation, they've been able to not only build a strong business case, but provide better care for patients and community. And particularly the partnership with UBC and the kinesiology students provides resources in the North that aren't usually readily available to our communities. So this has just been such an amazing program to be a part of and to support and watch grow. And most importantly, to see our communities getting healthier every day because of this program. So I'm just really excited to be able to be a part of it. And I'm hopeful that you're just as excited as we are when you hear about it.
Oh, hi, my name is Odo Honora. I'm a primary care physician and one of the physicians leading Change program. Our Change program is both a primary care and an interprofessional team based care. So the question here is, what is the relationship between Change program and primary care? The primary care is the foundation of successful medical system. And in recent years, there have been a lot of discussion and values being put in primary care. And primary care is actually being run by interprofessional team-based members. And the good thing about Change program is that it has both qualities. And in addition to that, it is also a patient-centered care. If you look at the diagram on the screen, you can see the patient located at the midpoint, and their care is being wrapped around the patient by different specialists, the exercise specialist, the dietitian, and the family physician. And the good thing is that the family physician of the patient that is involved, the physician that is involved at the program, during the program, after the program, just to make sure that the changes and the impact that happened during the program is being sustained. So why is Change BC different? We've heard and participated in different life modification program. A lot of patients have seen dietitian on their own or be part of exercise group. And there are a lot of things online that can support weight change and others. Change BC is not a weight losing program. It's a fitness program that helps patients to live through and to have their metabolic syndrome disease reversed. And the difference between Change BC and many other programs outside there is that it involves the family physician of the patient as the leader, a physician that knows the patient, a physician that helps in planning the care of the patient, that support the patient during the 12 months program and is there to make sure that the impact that is created during the program is sustained. This is different from when you have a patient see different persons without the knowledge of the physician and there's nobody to follow up. Change BC support interdisciplinary team, and it makes sure that the leadership is lie within the patient and the patient family physician. Another thing is that it's community sensitive. There are different challenges as it has to do with resources in different communities. We try to maintain the core ingredient of the program, but at the same time adapt it to fit with what is available in the communities. And it's also important to know that this is a patient-centered care. The care are being developed with patients and for patients, and patients are being supported. Different patients have different comorbidities. We factor this in during the planning, making sure that a patient gets the best and other medical condition does not limit the level of care the patient gets from this program. It is a team approach, having different persons involved, and a good part of it are the learners, the kinesiologist, the dietitian. We had a kinesiologist during the first pilot, and they made a huge impact in the program. There is a regular follow-up and a check-in. We have, follow-up, frequently during the first 3 months. After that, the patients are being followed up as needed, and patients can call in and check in with the family physician, who is the physician he knows very well, checking with the dietitian and the student or kinesiologist that are involved, just to make sure that the program and the impact is being sustained, and the patients are not being left on their own to go through, the different the training. There is patient empowerment. This is important because patient activation is huge. We are not just providing care, we are training patients to be able to know their health challenges and to make an impact that the patient can sustain even after the program. there is adequate time for patients to make changes. 12 months period. It has been, confirmed that this is enough time for us to see the changes during the program and for us to sustain it, for us to create enough impact and create the skill of the patient so that the patient is activated and is able to sustain the learnings after the 12 months. The relationship is important here. The family physician of the patient is involved, and the patient is working with a team that understands the team. And this is one of the testimonies we heard from the participants. They speak much more about the relationship. And it's important that a program like this is existing to support patients on a personal level and to build a relationship. So we actually had a survey 12 months after the pilot program. This is to determine the level of the patient experience and also the level of activation of the patient. 100% of the patients agreed that the change program was relevant to them. The same number of patients agreed that the program helped them to understand their health issue, which is important. People that have diabetes get to understand, why am I having diabetes? Why is my blood pressure high? How can my cholesterol be high and why? 80% agreed that the program increased their knowledge and helped support available to them. Some of them, or most of them, did not know that kinesiologists can play a role in their care. And there are resources in their community that could be helpful to their care. Through this program, they get to understand that. 61% agree that attending the section with other patients added value to them, and all the patients agree with seeing a dietitian and a kinesiologist alongside with their family physician added value to them. Thank you. I pass it to Dr. Greg Linton.
Thank you. I'm joining you from the unceded ancestral and traditional territory of the Simpson Nation, and specifically the people of Kitsum-Kalem today. You can see from this current slide, the area outlined in yellow encompasses the Pacific Northwest Division of Family Practice, and it is a substantial geographic area. And it's the size of that area will determine the success of the change program, how it's rolled out. And what we've learned from COVID-19 virtual care is that virtual care can be a strong component of reaching people in rural and remote areas. So one of the aspects of the change program that's important here is the fact that while face-to-face is the preferred method of us interacting with everybody, there is a component that can rely on virtual care as well. One thing that we want you to know as physicians, both Dr. Otto and myself wear a lot of hats in our communities. So besides being involved with the Division of Family Practice, I am also a site director for the Family Medicine Residency Program, a distributed program from UBC. And our rural Northwest program is based in Terrace. I am also a preceptor with the clinical clerkship program, third-year medical students, 3 of whom spend a year in Terrace. And so one of the things that we're used to in Terrace is dealing with students. And as part of the change program, we have a relationship that we've developed over the years with the kinesiology department as well as the dietary department at UBC. And there is a lot to be gained from the team-based approach when you are looking at educating learners within that multidisciplinary team from the outset as well. And so this is one of the highlights that we see as successful for the change program, not only for the educational component and for the soft launch that we've started here in the Pacific Northwest in the last few weeks, but also longer term in terms of recruitment and retention of these healthcare professionals as part of our team-based approach to the delivery of primary care. So one of the reasons that we've had success here in development of the change program is that both Dr. Otto and myself have been able to spend a significant amount of time with the team developing a team-based approach that requires us to actually get off the dance floor of family care in the office and in the hospital and in clinics and get into the planning mode. So every Friday, Change BC meets for an hour, and we've been meeting at 7:30 in the mornings for over a good year, and longer than that on a less frequent basis. But again, for all of the team to be gathering, this is one reason that we feel we've had success. When you get to how this looks in the family physician's office, we have electronic medical records that we utilize. And part of what we do is to determine the group of patients that are going to be eligible for change. So that's not only those with metabolic syndrome and those with type 2 diabetes, but also those with 2 out of the 5 criteria that are required for a diagnosis of metabolic syndrome, which of course is a requirement of 3 out of 5 of these criteria. And so what you see before you is a screenshot of my EMR with both male and female patients represented in pie graphs. You've got in the top middle, males with 3+ criteria, and you can just see the numbers of people involved. With one click of a button on my electronic medical record, I now have access to the exact group of people who would be eligible for the change program based on the criteria that we've utilized. So that's sort of from a general sense of recognizing the population of patients. And then when we call our patients in, here is an example of the primary or initial assessment that we utilize when we're bringing someone into the change program. So you can see that at the very top, we've got criteria for inclusion, which includes reviewing their labs, determining if they're in fact eligible, determining if even they're ready to partake in this program. And then we've got blood pressures and heights and weights. And below that, we also then have some launching of what says the PHQ-9 and the GAD-7, which are screening questionnaires for both depression and anxiety, recognizing that when we're talking about lifestyle management, that mental health can have a significant impact on people's ability to partake in this sort of thing. So these are screening questionnaires to see what is the underlying mental health of a patient that's about to enter into this program. We also look at cardiovascular risk factors, and below there's the Framingham risk score. So the template that we use, and this was developed with myself and our practice support coach, Tamara Stevens, the template that we use is about 3 different screens long. I've decided to not show you the entire thing, but to give you just an example of what's involved. And with the next slide, you can see a little further along in the initial assessment process that we have down through here, launching Change BC referral package, the Change BC contract, because there's a contract we want the patients to sign that they understand what's involved. There's nutrition assessment handouts, lab work that we request of them because we check it at time 0, 3 months, and at 1 year. And then if required, because there is a portion of this change program that also now involves people that have had cardiac events, so possibly just had a myocardial infarction or a heart attack, or maybe they've had a stent placed, they can now also participate in the rehab side of this change program. So if you haven't had a cardiac event, we call it prehab. And if you have had a cardiac event, we call it then rehab. And so we involve internal medicine as part of this team as well to do an initial assessment. And below then, with launching the Change BC Passport, you see various options here for overcoming barriers to eating vegetables, fruits, metabolic syndrome fact sheets, local traditional diet, and I'll just turn attention to this for half a second to let you know it's been an iterative process over the years since we launched our 2018-19 pilot. We have now included a portion of this that is culturally relevant. Initially, it was a Mediterranean diet, but we recognize that this is not necessarily a culturally relevant diet to a vast majority of the people in the Pacific Northwest. And so we're in the throes right now of adapting our program to include traditional diets as well as traditional land-based exercise. And what you can see here is an example of the launch of the referral to the kinesiology and dietitian portion of our program. And so we use one form for both the referral to the kinesiology and dietary side of things. And they gain the information here about the patient that's required for their assessments. And this is all launched out of the template that I showed you earlier. I guess while we're getting the next slide ready, you can also see down at the bottom under waist circumference that it's not applicable to Indigenous patients because there's no cultural norms that have been developed for applying abdominal girth or waist circumference. And so to utilize that doesn't make sense within the Indigenous category. And so we've just drawn attention to that with our form. And finally, I would like to suggest to you that over the last few years since we started the pilot project, and now we've been presenting this to various entities around the province, that we kind of feel like we're gaining momentum with this. The Pacific Northwest is the first division of family practice in the 35 divisions around the province that has adopted the change program, and we're embedding it in our primary care network, which is a first in BC as well. And there are other divisions around the province that are very interested in applying this to their PCN planning as well. So we feel like we're getting this snowball rolling in the Pacific Northwest, and long-term we see it going to be rolled out and applied to all the divisions that are interested throughout the province. Thank you.
Thank you, Dr. Linton. I'm Robert Bushell. I'm professor and director of the School of Kinesiology. I will lead off the next group of speakers from UBC's perspective and engagement in Change BC and involvement with the Pacific Northwest Division of Family Practice. I'll begin by commenting on the importance of exercise in the field of kinesiology for health. There's a vast amount of research that really now recognizes the powerful effects of exercise in chronic disease prevention and also health promotion, whereby we're not only able to describe health benefits, but understand mechanisms from the molecular level to organ system changes that are really clinically relevant. And this has led to position stands by for example, the American Heart Association position stand that exercise testing should be part of every physical exam in primary care, and other organizations commenting on just the importance that exercise has directly in primary care practice. Similarly, advancements in our knowledge of the science of food, and Ricky Yatta will follow me with the dietetics perspective, the powerful effects of food, even to the level of affecting gene expression, and of course, increasing body of knowledge that is revealing the powerful interactions between exercise and diet and their effects on systems and the physiology towards health. So I'll just briefly say how we began with this. 2018, I was delighted to receive a call from Colleen Enns in the Pacific Northwest to express her interest in the interests of physicians in the division in the north of including exercise in their primary care networks. And this was a delight to us. Ricky Yatt and I had been part of UBC Health and had been really promoting the idea of exercise and diet in the framework and vision and strategy in the early days of UBC Health. So we jumped on the opportunity to engage with Colleen and the Northwest Division, and had the opportunity to rapidly mobilize some students who were in co-op placements to move to the north, and they were situated in that pilot project that Dr. Linton had spoken about in 2018-19 in 3 different sites. And as mentioned, as part of a study, saw a profound effect of a 32% remission of metabolic syndrome over the course of a year. And that's consistent with other studies on diabetes remission with diet and exercise intervention. And fast forward to where we are right now with 13 kinesiology students, 6 in person in the north in 4 different sites, and 7 students working virtually, and building capacity and systems and the various components of primary care elements around change as we go forward. And much to our delight, last year, Colleen communicated that kinesiologists, as well as dietitians and other professionals, were approved by the Ministry of Health as part of the primary care networks. As described, we have regular meetings, so you can see on the bottom a screen capture of our regular Friday morning meetings. There are more meetings than just once a week, so we've really built a strong community of professionals supporting one another who are really dedicated to patient health. Can you prompt further to the next slide? Yeah, keep going so we see the text. And then built a structure, as Dr. Linton and Odo have described, around multiple components of both the management and systems, and also delivery to patients in an interdisciplinary approach. And so with this, we were able to roll out effective programming remotely, but also in person and connecting through networks. We've been really fortunate to have enhanced all of our program delivery, interactions with patients, and prescriptions and approaches to exercise and diet through the wisdom of Indigenous members of the community who provided relevant, culturally sensitive knowledge and traditions and perspectives on health that really enriched all of what we do in the Change program, from food, traditional foods, to land-based physical activity, and also advising students in culturally sensitive and appropriate ways of interacting with patients. As part of this, also, we are embedding a research approach into the Change program, the engagement of kinesiology students, and into primary care, where we're able to integrate some of that knowledge that comes from the community to bridge from our knowledge in research from the laboratory here at UBC into the field, and expanding into new areas of our thinking around the importance of traditional foods and traditional land-based activity that is also really impactful for health, that can also be part of what we can conceive of as prescriptive with known physiological health promoting effects. So over to Ricky.
Great, thanks, Rob. Good afternoon, everyone. I'm Ricky Atta. I'm the Dean of Land and Food Systems here at the Vancouver campus, and I'd like to do a land acknowledgement. I'm speaking to you from my office in McMillan Building, and we're grateful to be on the traditional, ancestral, and unceded territories of the Musqueam First Nation. Just to pick up where our previous speakers, Laurie, Dr. Menodo, Rob had talked about the importance of nutrition and exercise to health status, to primary care. So a bit of history. our team, as part of TBC, started off with the minimum number 2, Rob and I. And the fateful day was in November of 2015 when Rob came over. He was newly appointed as the director of the School of Kinesiology. We're fortunate enough to have a common friend from the place where I was at, the University of Guelph, Terry Graham, who again was an exercise physiologist, but was a firm believer of the importance of nutrition and exercise to health status. So Rob came over and we had a wonderful first meeting, and we talked about food, diet, nutrition, and exercise and its importance to health status. But I guess the bottom line was that Rob and I were passionate about preventative health care. It's I guess, a philosophy that is still fighting a bit of a battle, using food and exercise as a means to keep people healthy. And this is where we started, and we were fortunate enough then to transition into the Change BC group. So thank you, Colleen and colleagues at Change BC and the Pacific Northwest for embracing the concept. So a bit of self-promotion, and I apologize, but a little bit about the dietetics, which Rob talked about and Dr. Linton talked about, having kinesiologists and dietetic students involved in healthcare. We're the only program in the province to have a dietetics program. It's a competitive process to get into the program. We admit about 35 to 40 students. And at the end of their program, they have the designation of registered dietitian. Now, like most healthcare professions, the demand outstrips the supply. And we're looking at how do we increase our number of dietitians outside of the bachelor's program. And something that I'll talk about right now is that we just got approval for Masters in Nutrition and Dietetics that will begin in September. And this will be an alternative route to the registered dietitian's designation. But a little bit about our program. Our director of our dietetics program, Tamara Cohen, and I have had a very, very good series of discussions along with colleagues on campus about the importance of building into our dietetics program Indigenous health and social justice. We're also building into the program business and entrepreneurship. And of course, the thing that I think students really enjoy at universities is having a experiential learning experience. And this is gained through our capstone research project, where they get to actually apply some of the concepts that they learn in the classroom to actual real life situations. So just as a reminder for those joining us today, dietitians in primary nutrition care are seen in various positions, and here are some of them. I won't read them off, but the bottom one is really important to us now is our working relationship with kinesiologists, physicians, other healthcare workers. Carrie, who's going to follow me, Carrie, I don't know if you know this, but I had a very good discussion with the previous dean, Chuck Schuler, and about the whole importance of diet and nutrition to oral health care. And Chuck was a passionate believer in the relationship between those two entities. So the point I'm trying to make on this slide is that faculties on campus should be viewed as administrative units, not as barriers to collaboration. And I think as in keeping with that thought, Rob and I have just been able to secure a joint appointment. The person will be joining us as of, I believe, Rob, July 1st, Dr. David Wright, who comes from the University of Guelph. But David is an exercise physiologist, but one who has been trained in nutrition. So we look forward to working with David, and David will be kind of exemplar of how relationships and joint appointments should work. So with that, I think I'm turning it over to Carrie. So Carrie, over to you.
Thank you, Dr. Yada. Good morning, everyone. I'm grateful to be joining you as a settler on the beautiful unceded ancestral territories of the Musqueam people. So just to echo what Dr. Yada said, there is a lot of linkages between oral health and general health, diet and exercise and metabolic health. And there's a bidirectional link between gum disease and diabetes. Gum disease and metabolic disease share several risk factors, including some of the things that we don't commonly think about in health, such as the social determinants of health, which make this team-based interprofessional approach to early detection of metabolic disease so valuable. But gum disease is also a warning sign for undiagnosed metabolic disease. And I can tell you from experience in more than 30 years of clinical practice that often we are sending folks over to the physician because we're seeing things unexplained in the mouth. Metabolic syndrome is associated with the progression of gum disease as well as cavities and tooth loss, and that's well established in the literature. And if you have active periodontal disease or gum disease, you'll have a more difficult time with your blood sugar control and be at a higher risk for other complications like cardiovascular and kidney disease. So periodontal therapy or gum disease therapy can help reduce your blood sugar levels and help control your metabolic syndrome. So the integration of oral healthcare professionals in primary care is a very new idea, but it can advance the efforts to manage metabolic syndrome and other infectious diseases and help us improve patient outcomes. So with the promise of federal funding for dental care, the opportunity is ripe to incorporate oral health in the team approach. And I just wanted to say this is really exciting because I've believed this for a very long time. And this is really neat that so far we have integrated some oral health screening questions in the dietetics intake or dietitian's intake and developed some clinical and patient educational resources. So what's next is the mapping of community and other resources that we can leverage, including funding, local clinicians, and students, much as they've done with the kinesiology students. But I thought I would take a minute just to talk about some of the unique enablers that I've observed being welcomed as one of the newer team members on the Change BC team. Because adding an oral health component to a care model doesn't happen overnight, and it must be carefully staged as there's a butterfly effect that can impact all of our team members. And we know from COVID-19 that it's important to protect the mental and emotional and physical health of our healthcare workers. So I really appreciate each Friday morning meeting as we have an opportunity to get to meet each other. I can orientate myself to the team members' roles and processes, make suggestions, and discuss strategies with the other team members. It's really the collective knowledge of these team members that helps us make better decisions and see the possibilities. So Change BC has really committed to ongoing communication, a shared leadership model, and a learning culture mentality, which makes me feel safe to speak up as one of the care team members. So the most important thing here, I think, is the value on building trust and sustaining relationships in the team. And I look forward to our journey ahead. So I'm going to turn it over to the students. Yeah.
Awesome. Thank you, Carrie, and good evening, everyone. So as a part of the Change student team, I'll be discussing, along with a few colleagues, some of the learning experiences and perspective of students in the Change program. So in the past 5 months, we've been preparing for the process of going up north and actually participating in this team-based initiative of Change BC. On the right there, you can see a photo of the entire student team. This is including the folks coming up north, as well as the Vancouver support students. So through this initiative, we've all had the opportunity as students to collaborate with medical doctors, CCHRs, dietitians, practice support coaches, and basically a whole bunch of other organized health clinicians. So through this, we've been able to place in 3 different areas, including Terrace, Smithers in Houston, and Nisga'a Valley. And through this, we've also had the ability to collaborate with faculty directors, including kinesiology, land and food systems, dental, and dietetics. So throughout a very overall and well-rounded group of healthcare providers. And through this, we've not only built a diverse clinical application of skills, but also learned how to apply them in a very practical setting. So now I'll be passing it down to Vienna to discuss a little bit about the virtual systems.
Awesome. Thanks, Ahmed. So my name is Vienna. I'm one of the master's students as well, heading up the Vancouver-based team. So 7 of us are down here, like Dr. Bouchel mentioned, and we are supporting our team up in the north through logistical help and then also providing some virtual availability. So we've had many things that have come up in the past 3 weeks as students are getting settled into their placements. Things like emergency action plans that need to be written, setting up communication lines between patients and our kinesiology students, and then also continuing to create some supplemental material for exercise and nutrition education. So we are there to do all of that logistical background work just to make sure that our students are able to focus on their in-person patient interactions. And we've also been really lucky to stay connected with them as well. So through our many virtual meetings in the mornings every week, the students have brought up different patient case studies or just different challenges or small celebrations that they like to share with the whole group. So we have a safe space for students to talk about in a roundtable style discussion about different patient care plans. And we all had different experiences that we've been able to bring together to offer the best care for the patients that we've been lucky enough to work with. Beyond that, we are also working on the longevity of the program beyond our summer placement students. So writing up those operating procedures, applying for different grants to keep up our training needs and continue to bring on students so that this program can stay within or can extend beyond our summer placements. And then I'll pass it on to Carmela to talk a little bit more about learning and team-based care.
Thanks, Sienna. Hello, everyone. My name is Carmela. I am a graduate student in the UBC School of Kinesiology. And prior to my graduate studies, I did practice kinesiology for a few years as well. And through all of that, I've seen working through Change BC and learning through Change BC is so unique. Nothing like it, at least that I've seen from Vancouver Island, which is my hometown. And I'm coming to you from Terrace right now. So learning in different space is just one of the aspects that makes working with the Change program so unique. But what it really offers our students is the opportunity to take what they learn in lecture and from textbooks and immediately apply it clinically to a unique patient base. And they get to practice their skills and refine their skills in movement and cardiovascular screening and prescription, as well as practice building patient rapport and those soft skills that we probably know can't really be taught through lecture or textbook, and something that is taught to us mostly by our patients in our practice. And being able to make that accessible to undergraduate and graduate students is bar none, and the best way to be better in their practice after they graduate. And I think what makes it most unique, learning in team-based care, is that learning in team-based care means team-based teachings. This is beyond your regular preceptor-student model. We don't have one person to ask and troubleshoot with. We have a whole team. We have a whole team of students where we get together and we troubleshoot and try to provide the best care. We work really tightly with our physicians and our dietitians who are there to mentor us. Of course, we have our patients mentoring us along the way because care is centered around them. And what has really stood out to me so far, being in the Pacific Northwest, is how much our health administration and the local government administration really needs to be listened to and is an integral teacher to us also. So, like I said, I'm in Terrace. We have students in the Nisga'a Nation, and the way that they collaborate with their First Nations Health Authority and their local governments is very different and looks different from how I do it here in Terrace and how our students in Smithers and Houston do it. And that's the way it should be. This team-based learning and team-based care needs to be catered to each space that we work in. And I haven't seen anything like this offered to undergraduate and graduate students alike. So it's been an honor to be able to feel that firsthand and continue to learn like this in my graduate studies. I'm going to now pass it on to Mary Lou McKay, someone who, one of our elders who has mentored us. Oh, sorry, before that, our next slide, here's just a quick picture of some of the fun that the students been having, much learning, but much fun here in the Pacific Northwest, and memories that we will probably never forget. So just some pictures of joy from all of our students there. But off to you, Mary Malou.
Hi there, my name is Mary Lou McKay, and I'm speaking to you from my home in the Nisga'a Valley in the village of Lachkalzap, or also known as Greenville. As a person living with diabetes, I'm very thankful for Change BC coming into the beautiful Nass Valley. Every patient will feel supported on a personal level with care and guidance from the doctor, the kinesiologist, and the dietitian. And now the dentists. I am very, very happy to hear about the dental hygiene portion of it. A stronger team working together to reach a goal. This is an opportunity for our community to learn to prevent and manage diabetes in a healthier way. Now we can continue to educate our grandchildren, our children, to enjoy life with a higher education and awareness about diabetes. Thank you.
So thank you all so much. What a great program. So inspired by the Pacific Northwest Division and how you've connected and brought the team together and now are expanding the team and again, engaging the community and First Nations. Perspectives, I think, what a wonderful program.
Thanks, Christy. And I also extend my thanks and appreciation to the team for your excellent presentation today. I also want to take a moment to mention our new approach to engaging panelists for our TBC at UBC network events. The network offers a forum for those thinking about and working towards team-based care to engage in meaningful dialogue. And participation in the network events provides an opportunity to share your ideas, build connections, and contribute to the conversation that we're building provincially about the questions and ideas that are important for team-based care in BC. And so to that end, for individuals working to advance team-based practice, education, and or research, we invite you to convene a panel that is interested in disseminating learning, stimulating dialogue, or exploring emerging questions. UBC Health will be making some funding available along with support from the UBC Health team to those that are accepted to participate. And it's going to be on an expression of interest basis. We'll be launching the call for those expressions of interest sometime over the summer, building for next year and the year after. So please keep an eye out for additional announcements that will come shortly. I'll also add that the network events link to other opportunities to promote ideas and resources for team-based care. UBC Health, with UBC Health, with the Doctors of BC, with the BC Patient Safety Quality Council, and the UBC Innovation Support Unit. And together, we're working together to aim to offer a responsive and integrative approach to learning and research about team-based care in BC.